Welcome to Season 8 of the Prosthetics and Orthotics Podcast. This is where we chat with experts in the field, patients who use these devices, physical therapists, and the vendors who make it all happen. Our goal? To share stories, tips, and insights that ultimately help our patients get the best possible outcomes. Tune in and join the conversation. We are thrilled you are here and hope it is the highlight of your day.
Hello, everyone. My name is Joris Beals, and this is another episode of the Prosthetics and Orthotics Podcast. How are you doing, Brent?
Hey, I'm doing well, Joris. You know what's crazy? This is, I know we've said this before, but we are just a few episodes away from our 100th episode. Can you believe it?
No, cannot believe it. Cannot believe it. I still enjoy the hell out of this. I think it's wonderful. I think it's absolutely wonderful.
Well, and we've learned so much. I mean, that's the crazy thing. And here's the other thing that's very interesting. You know, you have sometimes, and I think it's just the human nature of some of this. You have some preconceived notions of people that you interact with, and then, or maybe you've heard something from someone or what have you, and then you have them on a podcast like what we've done, and it's like kind of shatters the preconceived notion. And I would say, everybody that we've had on has been, fantastic, generous, obviously with their time, but it's just been great. There's something about face to face and getting to know somebody that really humanizes the whole field as well.
Totally agree. And this podcast episode is, of course, brought to us by Advanced 3D. And what is Advanced 3D? I think they do prototyping, they do MGF, they're like the workshop for the prosthetists and orthotists. Well, what are they doing?
Yeah, so really what Advanced 3D does is try to meet clinicians, orthotic and prosthetic professionals, wherever they may be. They may have never scanned before. They may have never designed before. Maybe they're wanting to try to do test sockets or FDM something. Maybe they got a bamboo printer and they're like, hey, I want to do something more than Thingiverse. Or they want to take it further than that and they want to get into definitive style devices that go on patients. We just want to meet you where you are and then come in alongside of you and help you with that journey wherever you are. But then again, like you said, we also do prototyping and that sort of thing, product development. So if you have an idea, we can bring that to life as well.
Sounds wonderful. So that's Advanced 3D. And then, I think it's interesting. We've learned so much about this industry. We've learned so much about these people. I think one of the things that is we always start with this, because it's kind of like universally, the backgrounds of the people are different. Everyone has really different types of thinking, ways of doing things, and then methods and stuff. But generally, we can see that the paths to prosthetics and orthotics are really usually quite convoluted and all over the place. We've got tons of people coming to us from different directions and stuff. And so I think it's always exciting. It's never I wanted to be a doctor since I was 5 years old, and then I went to med school. It's always I did this, and then I did this, and then I saw this thing, and then so I'm always really excited for our first question, which we're going to ask for another new guest. Who's our next guest, Brent?
Joris, I'm so excited to have Jim Reichmann on the show today. This one's going to be a little bit interesting, and I know I say that almost every time, but Jim actually just said that he has retired. He's switched over to a Mac. I guess that's what you do when you retire is you switch to Mac and iOS products. But what's interesting about him is he's not only been in O&P, he's also been prolific in the research side of things. He has over 19 PubMed articles. His stuff has been articles have been in things like the PM&R Journal, American Journal of Physical Medicine and Rehabilitation, Journal of Vascular Nursing, the Prosthetics and Orthotics International, as well as Physical Medicine and Rehabilitation reports. He's done a ton of kind of outcome measure type of things, evidence-based guidelines, clinical guidelines. So I think we're going to have a lot of fun today talking about that and kind of its role or potential role, current role in orthotics and prosthetics.
Awesome. So Jim, you just heard me people come to this industry from all sorts of walks of life, all sorts of different backgrounds. How did you get involved in O&P?
Well, Joris, I'll tell you. First, I want to say congratulations on your near 100th podcast.
Oh,
That's
thanks.
really a great milestone. And thank you for having me. I really appreciate it. The way I got involved in O&P, after a fairly long career of managing clinical services businesses, one managed high-risk obstetrical patients, another one managed complicated respiratory patients in the home, where you have that relationship with the three Ps, the payer, the patient, and the physician. I managed a couple of those businesses and then was recruited and came to Hanger Clinic as the vice president of sales and marketing nationally for Hanger Clinic. So that's how I came to O&P. And that's where I really discovered the topic that we're going to spend some time talking about today, which is removable rigid dressings. In my previous roles, Joris and Brent, I had created evidence-based medicine, written articles, done some research, and created stories, if you will, around the evidence that was already published and significantly well-known, usually, to support the services that I offered or the products that I offered.
Okay, and then so what was it like coming in? Because you came in, you started with this big company, or for us, it's a big company. In this industry, it's a big company. What was that like? Did you survey the landscape and saying this is something that we should consolidate, or this is something that we should spread quickly, or were you just really kind of in a going really slow at the time?
No, that's a great question, George. What I did was I looked at the Hanger clinics. Hanger has over 800 clinics throughout the United States. And I looked at the Hanger clinics that were high-performing clinics. And when I looked at those high-performing clinics, I really wanted to look at where those clinics had deep penetration in prosthetics and had well-established relationships with physicians that were doing amputations. And when I looked at those and began to look for some common denominators, it wasn't always the case, but quite often it was the case that those were the clinics that used a removable rigid dressing. The Hanger device is called an AmpuShield. And when I saw that, I was like, wow, that's very, very interesting. And so I went out and talked to the clinics. I went out and talked to the physicians that were using the devices, and they had nothing but wonderful things to say. So I thought, well, let me go back to my previous background and let me look at the evidence. Let's see what the evidence shows on removable rigid dressings. And that's how I began, if you will, my journey around removable rigid dressings.
Okay, and then so this, but I think it's interesting that you clearly want to talk about this dressing thing. We'll go into that a bit, but it's interesting you picked out this one data point as being so significant. So why did you think what is this removable rigid dressing, and why is it so significant for the performance of the clinic, in your opinion?
Well, I think the real issue, and this is an important message for all your listeners, is that it allows the clinician, either the prosthetist or a sales rep, if they have sales rep in place or a marketing person in place, to sit down and no longer think about acquiring the next patient from that surgeon, but rather acquiring that surgeon's practice. Because the removable rigid dressing allows the O&P provider to establish themselves within the protocol of that surgeon so that they do the same thing every time. So consequently, you get all that surgeon's referrals, not just one or two of them, and then the next one goes to the next guy, and they bounce them around. And so that was significant.
Hey, we're going to stop right there for just a second to recognize one of our new sponsors for the Prosthetics and Orthotics podcast, and that is LimbGuard. LimbGuard is essentially a helmet for somebody's limb right after they've had an amputation. And research shows that it dramatically reduces the need for revision surgeries, which not only costs hospitals, physicians, and insurance companies thousands of dollars per patient. One of the neat things is that you, as a prosthetist, don't have to stock a bunch of different sizes and sides. One of the other cool things is that you can put your clinic name and contact information right on the LimbGuard itself. And so once the patient discharges from the hospital, they know exactly who started with their care. It's a great way to become part of the clinical team by providing this care up front and ultimately a great outcome for the patients. So check them out. And thank you for sponsoring us, LimbGuard. Let's get back to the interview.
Okay, I like that because it does seem like a bit of a kind of it is a bit kind of random that one time they'll go to you, the other time they'll go to someone else, and maybe they'll forget about you. And that seems like if you look at that as a constant revenue stream, that's nice. But it also does it also deepen the relationship? Does it also mean that now he knows your name, now he trusts you more? Does it also like do that or?
Oh, absolutely. And I'm sure Mike from Limgard spoke about this. It allows you to, as I said, you become a part of their standard operating procedure for an amputation. They do the amputation, they call in the provider with the removable rigid dressing, and right away, and it's either applied uh, in the operating room or in recovery. And you've already tagged that patient, if you will, too. You've established a relationship with that patient, so that ultimately you're most likely going to get that prosthetic referral. And you have you're now in the clinical practice. So when I talk about, I used to talk to the prosthetists at Hanger, and I would say prosthetists have the opportunity to go the way of respiratory therapy or go the way of pharmacy. And by that I mean, and I've had experience with both. By that I mean the respiratory therapist continued to bow to the surgeon or the physician to say, "What should I do? Tell me what to do next. I'll do whatever you say." And the pharmacist is a clinical consult, an equal clinical consult with the physician on medications, and the physician leans on the pharmacist to say, "What drug should I use in this situation?" Or if they get a call and say, "Hey, there's an interaction with these drugs. What do I need to do?" And the process has the ability right now, it's at a crossroads. They can either do what the doctor says and just follow orders and become like a respiratory therapist, or they can become like a pharmacist and be an important component of the clinical practice of the surgeon.
So, what should we do, and how do you do it? Because okay, I'm thinking you're leaning towards a certain choice here, but how do you actually do that? Because that sounds like a really difficult thing to actually implement.
Well, I think the way you do that is you bring something new and different to the practice, something that will absolutely, without question, improve the clinical outcomes, and consult with the physician on that procedure. So when you look at amputations, for example, there's four things that affect the clinical outcome of a transtibial amputation, and that's the surgical technique. And I always joke about, who the best surgeon in the United States is, right? It's the one you're talking to. And so surgical technique, postoperative dressing, site of discharge, and duration and intensity of physical therapy. Those are the four things that affect the outcome of a transtibial amputee. One of those, the prosthetist, has tremendous influence over, and that's the postoperative dressing choice. And so when you look at postoperative dressing choices, there's removable rigid dressings, there's soft dressings, there's hard casting or non-removable rigid dressings, and then there's immediate post-op IPOPs, post-op weight-bearing devices. And if you look at the market the way it is right now, and I published on this in PM&R Journal in 2018 in a comprehensive review article on removable rigid dressings, about 85% of the market is soft dressings with a neomobilizer usually. 14% is removable rigid dressings, and less than 1% are postoperative devices. IPOPs. And so it just is a shocking discovery when you look at that market share, when you go through the evidence and find that there are 20 peer-reviewed published studies that have been published since the beginning of time, starting with Dr. Wu, who invented the procedure at Northwestern in 1979, all the way to current day. There's been 4 published studies since 2020, and yet there's only 14% market share.
So there's a lot of white space. And I think the other thing that's interesting, though, when you're talking about all that stuff, is it really becomes a multidisciplinary approach to care and outcomes. And, I tie a little bit of this to the podcast that we just did a little bit ago of the osseointegration stuff, which is they understand that you have to have a really good surgery, right? And you've got to have recovery. You've got to have great PT. And then you've got to have somebody that can do the alignment. Yes, you're not talking about a socket anymore, but the prosthetist is still really, really involved and is, at the same level of all that. And it sounds as though not only is there white space that we can get better at just instead of a neomobilizer and an ACE bandage, now we can actually provide a clinically relevant solution. But it also gives us an opportunity to really make ourselves a valuable part of the rehab team.
Exactly. I could not have said it better, Brent. And it's just the outcomes, the postoperative goals they're the same. Everybody wants, to prevent damage to the residual limb due to falls. Everybody wants faster healing, volume reduction, avoiding rehospitalizations, and expediting prosthetic fitting. Everybody wants those things. And here's a device that can help bring those things to life.
I have a question for you on that. And I know it was happening during my residency, which was the early 2000s, but and you may or may not know about it, but there were some experimenting not only with the removable rigid dressings, but they were doing liners, non-covered liners right up against the skin, essentially. And then, like, if it got blood or anything on it, you just wash it off and dry it off and put it back on, and it still had a protector around it. Any data or anything on that? Or I'm trying to remember what the context was, but I always found that very interesting.
There was one study. There's not a lot of data on that. I am aware of it, and I've actually been in a room when one of those was applied to a patient. And there's the one study that was done was actually they applied the liner, and then over that they put a clamshell device. So that's one of the removable rigid dressing studies that I actually quote, and it was performed at WashU in St. Louis by an elite author's name is Dewari, and he did a matched control trial, a level 3 study that showed that if patients that were compliant, it was an important study because it showed that patients that were compliant with a prefabricated RRD or removable rigid dressing were significantly more likely to be successfully fit with prosthesis.
Oh, interesting.
And he's the only one that showed that. And so 72, they took all comers, everybody, if you can imagine that. And so 72% of those fitted with the RRD eventually ended up in a successfully fit with a prosthesis, as opposed to only 42% when they were done with a soft dressing. And there's a variety of reasons for that, but nevertheless, that was statistically significant. So that was a great study. And obviously, all prosthetists want the patient to get up in their prosthetic and be successfully fit. Just it's an enormous finding. The downside with the liners, I will say this, is they're just really tight. They're really tight. And at least the case I was in, it's an N of 1. I'm a study guy, but that's an N of 1, sample size of 1. But man, the only person sweating more than the patient was me watching it and listening to her scream.
So I remember when I was in my residency, I think Hanger, so I did my residency with Hanger. They were doing, this was the Kiwi. So
it's the one that's the one they were doing.
Oh, okay. So
that's the one I just quoted.
Okay, so I remember being in the OR. The patient had just had so I was in the OR. They wanted us to put the removable rigid dressing on, or it was the Kiwi. But I remember, you go in with the binder clips and the surgical tubing and all that stuff, and I forget what the outcome of was that or how it went, but it was actually very, very cool to do it right in the operating room as well.
Right, and the other problem with that technique is that if the wound does get infected or the suture line tears open or something happens, inevitably it's that device's fault.
Oh, of course.
Inevitably. Yeah. So don't delude yourself into thinking the surgeon's going to say that's all me. I didn't close as well as I should have.
So on that note, though, so I mean, you talk about all the different studies and such. Do you feel like it really resonates with the surgeons or the doctors treating the patients to see some of this data? I mean, they probably don't know that it exists. So I know you probably, as far as like me as a prosthetist, say I'm wanting to have a conversation with a doctor, or it's a referral source that I already have, and we're not doing this sort of thing. Do you find that this resonates with them?
It depends where I am. And so I've had some incredible success stories. So I did I was invited. I did a presentation, and a PM&R doc happened to see my presentation, and it was actually to a bunch of Hanger folks. It was at Hanger's Ed Fair, and their annual Ed Fair, and this physician was in the back of the room. At the end of when I went through every bit of evidence in excruciating detail, which I'm not doing here. Sometimes I like to beat him into submission, and so at the end of it, she said, "I want you to do grand rounds at Tier Herman Memorial Hospital in Houston with me, and we'll do it together." I said, I'm all in. I'd be happy to do it. So we did vascular grand rounds and we did orthopedic grand rounds. They both did amputations. Both departments did amputations. And they converted almost overnight to removable rigid dressings. But that's an extreme case. I guess I'll get into this because it's a great lead in. But people ask, well, why? The evidence is overwhelming, and I'm dumbfounded by this. It's just overwhelming, and yet why isn't the adoption rate better? And it's a valid question. Why isn't the adoption rate better? I'd say the first thing is nobody's out really selling it as hard as they can because you can't make any money with this. The only reason a prosthetist would do this, I think the Medicare rate is $500. Well, you got to go out to the hospital, you got to fit the patient, you got to do all this stuff, get time away from the clinic for $500. That's not the way to look at it. The way to look at it is I've made an impression on the patient. Everybody remembers the story about the dog who goes by the pond, and it's the first thing that the chick sees, and all of a sudden the chick thinks the dog's his mother. It's the same thing with this. If you're the first one in there, you're the one they're probably going to get the prosthetic with. And quite often, like LimbGuard's a great example, they'll actually put the name of the O&P on the device and the phone number. So they keep their patients. But the question is, why don't people do that? It's cumbersome to call an allied health professional, bring them into the hospital. Very cumbersome. And you got to time it right. You got to remember it. And these are surgeons. They're doing amputation, vascular reconstruction, broken leg. If it's an orthopod, they got 10 surgeries that day. And the clinical staff's just trying to clean the OR and get back into the OR. So that's one thing. And then the second thing is removable rigid dressing does touch the wound. And the doctors, the surgeons sometimes go, I don't know. I got a low infection rate now. My patients do great. I don't want to add something in the equation. And I encourage the surgeons to think of the outcome different because their endpoint is, and I gave this talk at the Society of Vascular Surgeons, 5 years ago. I said, you guys are all out there. Your endpoint is a fabulous surgery, a terrific suture line that's uninfected when the patient gets discharged when they leave the hospital. I'm encouraging you to think beyond that and think, can I get this person up walking again? Can I get them to activities of daily living? And when you start to think like that as a surgeon, you want them to walk in to see you 6 months for their follow-up visit, shake your hand and have you go, did I amputate this guy or this woman? Because they're so adept with their prosthetic. That should be the endpoint. And so there's a little bit of a disconnect between the research and what's done in clinical practice because of the cumbersome nature of RRDs and because it touches the surgical wound. Nevertheless, it can be done.
Okay. So a couple questions follow up on that. So getting the surgeons on board is super important, and it needs to be kind of part of the plan of care. And if there's like a operating procedure, essentially, it's like, hey, did you call the prosthetist? Do this, and it's just part of the journey. One of the things that we had somebody on where they talked about how much a doctor actually gets reimbursed for an amputation, which is it's I think he said $700-800. Like, it's not a lot.
Yeah.
And so it really becomes so this idea that, hey, I'm improving an outcome, and there's no money in it for anybody other than the outcome. That's a tough. I mean, for me, like as a surgeon, I don't want them back in my office, because the minute they come back in, I'm probably losing money for follow-ups or whatever like that. So, that would be one case for a removable ridge dressing. But I don't know. Like, I think it's important to tell the data, but then I think what you said is take it a step further. Is like, hey, when you're doing their 6 month post-op, okay, there's not a lot of money that you're going to get for them walking in without a limp or whatever. But how cool is it for somebody to come in and be walking after, whatever happened to cause the amputation?
Right. Well, I think you're onto something. I think that's the story and the picture that you have to paint. Because they do make surgeons get paid something like $700 or $800 by Medicare to amputate a leg. And I remember a discussion I was had with a surgeon that was like, those guys who do billboards for taking out varicose veins make $2,000.
Yeah.
To take out varicose veins, I'm getting paid $700 to amputate a leg. The interesting thing, and I'm sure you know this, is that amputations are done by the last guy that was hired in the group. None of them like doing them. They're a failure. They're a failure for vascular surgeons, and they're just nobody likes doing them. And just a little bit of epidemiology here on the field: 82% of amputations in the United States are scheduled amputations due to vascular insufficiency, and most of the remainder are transtibial amputees, are accidents, and then a very small portion are cancer, oncology patients. So, but one of the ways I think to hit home, I think you asked a good question, and it's a good way to transition, is to start to talk about falls, protection from falls. So when I went out and saw patients, physicians who used AmpuShield, they would tell me, I tried to learn from them. They would tell me, the only reason I use it is falls. And I would talk about, what about faster healing? And they go, okay, yeah, falls. And I'd say, what about shaping the residual limb? Yeah, falls. That's why I don't want the patient to fall. And so what's interesting is to look at the statistics around falls and amputees. In an inpatient setting, and I'll go through this data as quickly as I can. In an inpatient setting, the acute care setting, it's already been published, 16.5% of the transtibial amputees experience a fall within the 6 or 7 day window that they're in the acute care setting. 16.5. It's the highest fall rate of any patient in the acute care setting. That's higher than stroke. Now, so it's a small number of patients, but it's an incredible fall risk. In the inpatient rehab, depending upon what study you read, but somewhere between 19% and 32% of patients fall inpatient rehab. And this device protects them from damage due to falls. And in a community setting, pre-prosthetically, so from the time of amputation to ambulation, about 60.9% of the patients have fallen, either in the acute care setting, rehab, or in the community setting, in the pre-prosthetic phase. So it gets worse. 3 to 4.5%, and this is all published in the literature, 3 to 4.5% of the patients require revision surgery, which means that's a euphemism. They go back to the hospital to get their leg cut off a second time. And if it's in the acute care setting, a second time that week. And then in the literature, about 47% of those patients end up losing their knee. They get revised up to a higher level. And amputee fallers, so the hospital should be concerned about this too, because amputee fallers experience a length of stay in the hospital 32 days longer than a non-faller. So add 32 days to the 6 or 7 days. And, oh, by the way, it's a hospital-acquired condition, so Medicare doesn't pay for it. They're not paying for it. They don't pay for it. And there's nothing you can do to prevent these falls all you can do is prevent the injury from falls. And there's 3 studies that show when an RRD is used that the damage due to falls, revision surgeries are eliminated. And people go, well, you can't say that. I go, I can't tell you yours are going to be eliminated, but I can tell you the data on 3 studies show that not a single patient fell with an RRD and went back for revision surgery.
That's amazing.
It's pretty. I mean, it's pretty compelling. I don't know where you go with it. It's compelling. That story is another one that needs to be told.
Yeah.
By the prosthetists.
Well, I think from like also my side of things, when you say, okay, the removable rigid dressing, yes, it costs you time to go into the hospital. It's your reimbursement. It's essentially a break even. It's not a break even when you include the time. But for us, so like I'm thinking about East Point, and we do removable rigid dressings at the hospital that we're at. I think we do it from a little bit of a selfish role, as far as because we're in a rural North Carolina, so we do a lot of home care and such, and it's super important for outcomes for the patients not only to be ready, but to understand some of the prosthetic education side of things and that sort of thing. So the reality is our rate of follow-ups due to whatever is probably significantly less because of the protocol that's in place. And then we've got somebody with a more mature limb, somebody that's, understands the process a little bit more. And so for every appointment where we don't have to send out a van because of something small, it's a big deal to us. And so for me, that's what resonates. So it's not that initial investment up front, but it's really on the backside when we go and do a definitive prosthesis, we actually do save money because our trucks aren't on the road to go see these patients for I say silly appointments, but you know what I mean when I say that, appointments that could be avoided otherwise.
Right. I mean, that's an excellent point. I think the PM&R story and the process story is help me help you. Give me a better limb to work with. Give me a limb that matures faster. Give me a limb that's really well shaped. And I'm sure you remember from your Kiwi experience that the shape of those limbs was like textbook. They were ridiculously great, and so you bring up a good point. And I think the data is clear that the patients their limb matures about 60 days faster when we use an RRD compared to soft dressings. I published all this falls data with a surgeon, an orthopedic surgeon out at UC Davis, in Current Physical Medicine and Rehabilitation Reports just this past year. And we were invited to the editor of the journal had seen some of the work we had done, and he invited us to write an article exclusively on the problem of falls and lower limb amputees. And I conclude that by saying, do something to protect this limb from falls, because there's nothing you can do to protect the person from falling. It's no surprise that they fall. But when you put those into real numbers, that's when it's jaw-dropping. I talked about percentages earlier. In an acute care setting, there's 150,000 transtibial amputees in the year in the United States, and 24,750 fall during the first 6 days in the hospital. And so you start to look at that. What exactly does that mean? It means that 2,250 people in the U.S. every year, just in inpatient, 2,115 up to 3,172 lose their knee, and about 6,750 need revision surgery, unnecessary revision surgery, and then all those added hospital days. The other thing that's interesting is, sometimes the hospital's on the hook for this device. They have to pay for it because the insurance won't cover it. They say, it's covered under the DRG. Medicare doesn't pay for it, for example, for the hospital. The hospital can't bill it. So I put together a return on investment. So if a hospital does 100 amputations a year, about 3% of those patients will fall and require revision surgery. Revision surgery now is estimated. There was just an article published. I used to use the number 30,000 or 35,000 for unreimbursed amputation, transtibia amputation. But there was just a fabulous article that was published, peer-reviewed and published as an abstract in Value in Health that shows that it's more like $50,000 that it costs the hospital in unreimbursed amputations. So now that means they spend $150,000 for every 100 patients. They have to eat $150,000. That more than covers any costs that they would have to put the removable rigid dressing on every single patient. And the ROI, the return on investment, is somewhere $6 to $10 saved for every dollar spent. So it makes sense for the hospital to pay for this as well. It's just hopefully your listeners will get inspired by this. I know we're getting ready to wrap up. Hopefully they'll be inspired by this and go out and talk to their surgeons about the removable rigid dressings and capture these patients. LimGuard has a fantastic product that is available for the independent O&Ps. Hanger, I would encourage the Hanger clinics, any Hanger people that are listening to this, to use the AmpuShield and put that device on. And of course, the FlowTech device. The big three are AmpuShield, LimGuard, and FlowTech, share that 14%, 15% market share. And I would encourage them to go out and try to enroll their surgeons in a protocol that involves a removable rigid dressing.
Yeah, Jim, I have some questions for you, just more about like marketing and sales expertise. Let's say I have an individual clinic. A lot of these guys just seem to be like, we're here, let's wait until people walk in the door. What would you advise people to do on sales and marketing to really make sure that more people walk through the door?
Well, it's not hard to sales and marketing is only difficult if you make it difficult. By that I mean, if you set aside a day a week or a day a month, start out a day a month and list the surgeons that have referred to you in your marketplace, and go out and visit those surgeons, either cold call them or make appointments to go see those surgeons. Go out and talk about the patient you've shared with them already. So how do you turn one patient a year ago into 10 patients this year? You go talk about the success of that one patient. And it's a shared experience. You both have had success with that patient, and you can bring videos of that patient when they're in the clinic walking. The surgeons don't always see that. So how do you open that curtain and say, there's the patient. That's what happened eventually. Your surgical technique was impeccable. We overcame the fact that you put a soft dressing on the patient, and the patient had tremendous physical therapy and prosthetic fitting. And this is what we ended up with. That person today is now 40 pounds less than they were when they came into your office. Their A1C is down, 2 points, and it doesn't look like we're going to have to take the other leg. Doctor, you are phenomenal. Do you have any other patients that I can help you with like that? Don't sell, just tell. Tell them about the patient.
Hello.
Their patient. And I think that's the best way to do it, Joris. But that's a fabulous question because doesn't come naturally to most prosthetists.
And I think a lot of people are prosthetists that we've met through the show. Not a lot of them are very salesy. Is there a book they should read, or is there an attitude they should adopt where you think like, okay, you maybe not that natural born salesperson, but a lot of salespeople aren't. So is there anything advice you give them on improving their sales ability? Let's say.
I don't have one particular thing that I would point to say go study this, but don't think about it as sales. I guess that would be my message. It's not sales. It's not marketing. It's going out and talking about a patient that you together have had. And with that, all you have to do to make it a sales call, all you have to do is end that conversation with, is there anybody else in your practice I can help you with? Please think of me next time you have a patient that could use, that we'd like to have, that together we'd like to have the same outcome for.
Okay.
It's that because you're not closing. This isn't one of those hard, I call them press hard 5 copies close. This isn't like that. This is a clinical discussion, and you're the clinician that's helping. And that's again, that gets you closer to the pharmacist than the respiratory therapist. If all you do is wait for the orders to come in, you're not pushing the ball that direction.
All right, Jim, I think that's absolutely fantastic advice. Thank you so much for your time with us today.
Thank you. Thanks, Brent. Thanks, Joris. I really appreciate it. And again, congratulations on your near 100th podcast. And thank you for having me. I've really enjoyed it.
Thanks for being here today, Brent.
Oh, this was great. I mean, if this doesn't get people fired up about really great patient outcomes via something very simple to add to your practice, I don't know what will.
Cool. And thank you so much for listening, you guys, to the Prosthetics and Orthotics podcast. Have a great day.
Hey, thanks for tuning in. And a special thanks to LimbGuard and Advanced 3D for sponsoring this episode. If you enjoyed it, don't forget to like, subscribe, and share it with your friends. And if you feel so inclined, please leave us a review. Your feedback helps us improve and reach more listeners. Have a great day.